Parkinson disease is a chronic and progressive neurological disorder caused by degenerative loss of dopaminergic neurons in the brain that primarily affects motor function and is characterized clinically by asymmetric Parkinsonism and a benefit from dopaminergic therapy. Parkinsonism is a clinical syndrome presenting with any combination of bradykinesia, rest tremor, rigidity, and postural instability. Parkinsonism is a term that covers several conditions. This includes Parkinson's disease and other conditions with similar symptoms. The most common form of Parkinsonism is Parkinson disease. The prevalence of PD varies by geographic region, with higher rates of PD observed in North America and Europe compared to other parts of the world. The prevalence of PD is estimated to be around 1% of the population over the age of 60, although rates vary depending on the diagnostic criteria used and the population studied. The prevalence of PD increases with age, with the highest rates of PD observed in those over the age of 60. PD is more common in men than in women, with a male-to-female ratio of approximately 1.5 to 1. In Parkinson disease, loss of dopamine-producing neurons in the substantia nigra leads to a reduction in dopamine levels in the nigrostriatal pathway and striatum. The depletion of dopamine results in altered neuronal firing patterns, which ultimately results in increased inhibition of the thalamus and reduced excitatory input to the motor cortex, which is expressed as bradykinesia and other Parkinsonism signs. The exact cause of PD is not fully understood. However, epidemiologic studies provide important clues to potential risk factors associated with PD, including genetic factors. Several genes have been identified that are associated with an increased risk of PD, including alpha-synuclein, Parkin, and LRRC2. Environmental factors. Exposure to pesticides and other toxins, head injuries, and viral infections have been linked to an increased risk of PD. Age. There is consistent evidence that older age is associated with an increased risk of developing PD. Sex. Men are slightly more likely than women to develop PD. Race. Some studies suggest that Caucasians may have a higher risk of developing PD than other racial or ethnic groups, although more research is needed in this area. Lifestyle factors. Smoking, caffeine consumption, and physical exercise may have a protective effect against PD, while a diet high in dairy products may increase the risk of developing the disease. Family history. A positive family history of PD is also associated with higher risk of developing PD. The cardinal features of PD are tremor, bradykinesia, and rigidity. A fourth feature, postural instability, is commonly mentioned, although it does not generally occur until much later in the course of the disease and is thus not included in any published diagnostic criteria for PD. In addition to the cardinal manifestations, there are a number of other motor and non-motor features seen in PD that we will discuss. The tremor in PD, typically described as pill rolling, is a rest tremor, meaning that it is most noticeable when the tremulous body part is supported by gravity and not engaged in purposeful activities. Since Parkinsonian tremor decreases with purposeful action, it is usually the least disabling of the cardinal manifestations. The tremor of early PD is most often intermittent and may not be noticeable to others. However, as the disease progresses, tremor usually becomes evident. The frequency of the tremor in PD is between 3 and 7 Hz, and most often is between 4 and 5 Hz. Tremor is the presenting symptom in approximately 70 to 80% of patients with PD, and the percentage of patients with tremor at some point in the course of the disease is high, ranging from 79 to 100%. Tremor usually starts unilaterally in the hand and then spreads contralaterally several years after the onset of symptoms. The side that is initially affected tends to be the more affected side throughout the course of the disease. Bradykinesia is a generalized slowness of movement, and is present at onset of PD in approximately 80% of patients. It is arguably the major cause of disability in PD and is eventually seen in almost all patients. While it is the most common feature in PD, it is also the most difficult symptom for patients to describe. Weakness, incoordination, and tiredness are often used to describe the decreased ability to initiate voluntary movement. In the arms, bradykinesia typically starts distally with decreased manual dexterity of the fingers. Patients often complain of difficulty performing simple tasks, such as buttoning clothes, tying shoelaces, double-clicking a computer mouse, typing, or lifting coins from a pocket or purse. In the legs, common complaints related to bradykinesia when walking include dragging the legs, shorter, shuffling steps, or a feeling of unsteadiness. Patients may also have difficulty standing up from a chair or getting out of a car. As the disease progresses, gait freezing and festination may develop. James Parkinson defined festination as an irresistible impulse to take much quicker and shorter steps, and thereby to adopt unwillingly a running pace. Rigidity is an increased resistance to passive movement about a joint and occurs in approximately 75 to 90% of patients with PD. Rigidity, like tremor and bradykinesia, often begins unilaterally and typically on the same side as the tremor if one is present. Rigidity eventually progresses to the contralateral side and remains asymmetric throughout the disease. Cogwheel rigidity can be seen in PD, and the term refers to a ratchety pattern of resistance and relaxation as the examiner moves the limb through its full range of motion. This phenomenon is thought to be a manifestation of tremor superimposed on increased tone. However, not all patients with PD have cogwheel rigidity. Many instead will have lead pipe rigidity, a tonic resistance that is smooth throughout the entire range of passive movement. Rigidity can affect any part of the body and may contribute to complaints of stiffness and pain. Features, such as the striatal hand, decreased arm swing with walking, and the typical stooped posture, result, at least in part, from rigidity. Postural instability is an impairment of centrally mediated postural reflexes that cause a feeling of imbalance and a tendency to fall with a significant risk of injury. Since postural instability usually does not appear until later in the course of PD, patients with Parkinsonian signs who fall early in the course of the illness most likely have another Parkinsonian syndrome, such as progressive supranuclear palsy or multiple system atrophy, MSA. PD has traditionally been considered a motor system disorder, but it is now widely recognized to be a complex disorder with diverse clinical features that include neuropsychiatric and non-motor manifestations in addition to its motor symptomatology. These features include the following: cognitive dysfunction and dementia, psychosis and hallucinations, mood disorders including depression, anxiety and apathy, abulia, sleep disturbances, fatigue, autonomic dysfunction, olfactory dysfunction, gastrointestinal dysfunction, pain and sensory disturbances, dermatologic findings. The diagnosis of Parkinson disease, PD, is based on clinical history and neurologic examination. The first essential criterion is Parkinsonism. At a minimum, bradykinesia plus either tremor or rigidity must be present. An unequivocal beneficial response to dopaminergic therapy is an important supportive feature of the diagnosis, while the absence of an observable response essentially rules out the diagnosis of PD. The diagnosis of PD also requires absence of any absolute exclusion criteria, such as limb ataxia. In addition, red flags that suggest an alternative cause of Parkinsonism should be carefully evaluated and counterbalanced by supportive criteria in order to arrive at a PD diagnosis. Differential diagnosis of Parkinson's disease include predominant tremor, essential tremor, Other neurodegenerative disorders like dementia with Lewy bodies and atypical Parkinsonian syndromes, and secondary Parkinsonism like drug-induced Parkinsonism. Management of PD requires careful consideration of many factors. A wide range of symptomatic pharmacologic, non-pharmacologic, and surgical therapies are available to maximize treatment efficacy. Dopaminergic therapy is the mainstay of pharmacologic treatment for PD. In most patients with early PD seeking control of motor symptoms, we suggest levodopa as initial therapy. Among dopaminergic therapies, levodopa has superior effects on motor function, activities of daily life, and quality of life, and is often the best tolerated, especially in older adults. In select cases, initial treatment with a dopamine agonist, DA, monoamine oxidase type B, MAOB inhibitor, or amantadine is a reasonable alternative to early levodopa. Most such patients progress to require levodopa within a few years. For patients who fail medical therapies for motor symptoms and complications, device-assisted and surgical options are discussed by movement disorder specialists, including deep brain stimulation, DBS, continuous levodopa-carbidopa, intestinal gel, LCIG infusion, continuous subcutaneous apomorphine infusion, CSAI. Besides pharmacologic therapies and surgical options, there are non-pharmacologic interventions that improve patients' quality of life, such as education, social prescribing, exercise, speech therapy, and nutritional advices.